Good evening, consultants. Good evening, everybody on the call. Welcome to today's meeting. We'll begin with a discussion on right heart catheterization, and Dr. Okedara will be leading the presentation. So, Dr. Okedara, please, over to you. Thank you very much.
Thank you. Good evening, consultants, my chiefs, colleagues. So this evening I'll be talking about right heart catheterization. So I would like to acknowledge Dr. Ira Bolton for letting me use the slides and do some editing on it. Under the following outline. So by way of introduction, the first catheterization, sorry. Okay. Was done in 1844 by Claude Bernard, only that it was done on a horse. Then Werner Forssmann was credited with performing the first cardiac catheterization of a living person himself at the age of 25. Then later on, Forssmann, for his contribution and foresight, shared Nobel Prize in Medicine with Andre Courant and Dixon Richards in 1956. Then finally, William Gans and H.J.C. Swan were able to get an award for the Swansgan's catheterization for the right heart cath. That was in 1970. So by definition, cardiac catheterization implies the insertion of flexible tube into one or more of the heart chambers, usually under fluoroscopic guide, for diagnostic or therapeutic purpose. Right heart cath is an invasive procedure where a thin flexible tube, the catheter, is inserted and threaded to the right side of the heart to measure pressures, blood flow, and oxygen levels to guide diagnosis, treatment, and prognostication of cardiac conditions. Indications include suspected cardiogenic shock, evaluation of patients with dyspnea to diagnose or exclude pulmonary hypertension, constitutive pericardial disease, restrictive cardiomyopathy, heart failure with preserved ejection fraction, then to determine response to vasodilator therapy in pulmonary hypertension, diagnosis of cardiac tamponade in situation where echocardiography is non-conclusive or have a poor echo window, then intracardiac left to right shunt quantification like QPQS, guiding fluid management and hemodynamic monitoring of patients after surgery or complicated MI, heart failure, shock. So it's not restricted to cardiology alone, other conditions in which you have a circulatory issue. It can guide fluid management. Evaluation of congenital diseases, whether in adult or pediatrics, evaluation of cardiac transplantation before and afterwards for surveillance, post-cardiac transplants with new or worsening symptoms also, then pre-implantation assessment of LVAD, post-implantation also, then in valve disease when there are discrepancies between the clinical presentation you are having and the non-invasive investigations that has been done. So right heart cath can be the deal breaker. So this is just a table that summarizes all of the indications that I have talked about under heart failure, MI, perioperative use in cardiac surgery, pulmonary arterial hypertension. So contraindications include absolute and relative. So for absolute, right-sided endocarditis, right-sided tumor or thrombus, mechanical tricuspid or pulmonary valve prosthesis, uncooperative patients, then terminal illness for which aggressive management is considered futile. For relative, severe coagulopathy or bleeding diastasis, INR more than 2, platelets less than 20,000 to 50,000, bioprosthetic tricuspid or pulmonary valve prosthesis, newly implanted pacemaker or defibrillator unless fluoroscopic guidance is used. Then a patient that already has a left bundle branch block, because now having a right bundle branch block will give the patient a complete heart block. So usually it's advised that you have means of pacing available to be used in such a patient. So the equipment. Different pulmonary artery catheters are commercially available. Some can be used to perform thermodilution of having a thermosystor that can be used to perform thermodilution cardiac output assessments. I'm sure that severally that when we have answered different questions, we've seen questions like methods of assessing or calculating the cardiac output. We've seen the fixed principle, the thermodilution. So this is where one of the procedures in which it's done. So pulmonary artery catheter is about 110 centimeter long, and it can even be as long as 125 centimeter, because sometimes the length that you use can be related to the height of the patient that you are catheterizing. So French sizes of the catheter may vary between 5 French to 8 French. All catheters have distal yellow port and proximal blue port. I'm sure it is not. I'm sure that the color codes could change. So the presence of a thermosystor adds the third port to the catheter. So usually baseline would have 2 or 3 ports. So you could have one for the inflation and deflation of the balloon. There's one for measuring of the pressures, and then there's one for the thermistor. In the situation, there is an added port for possibility of checking the cardiac output using thermodilution method. So this is this image showing so this is the tip. This will be outside. So these are the ports, and this is the catheter. So this is the body, and this is the hub. So the tip will be neither too blunt nor too sharp. Although a tapered tip can help increase penetration when you are passing it through. Then the hub could be metal or plastic, larger than the catheter, of course. You have your tapered hubs, 2 or 3. So the right heart cut, like I said earlier, it usually has calibration. Some will be at every 10 centimeter. So there are landmarks at which you would pause to inflate or deflate your balloon. And it can be related to the height of the patient that you are catheterizing. So there are different types that have been used, but the most popular is the Songans with floating balloon catheter. So these are some of them. Coonant catheter. Set length is between 100 and 125 centimeter, 5 to 8 F. But disadvantage is it needs frequent flushing, especially in those with thrombotic tendency, like cyanotic congenital heart disease. You have to take more caution. So this is another one. Okay, so this is this has 2 to 3 lumens, like I mentioned earlier. Balloon tipped floats through the right side of the heart safely and easily. And size between 5 to 7 F, some say 5 to 5 centimeter. So uses wedge pressure measurements, occlusion angiogram in coronary sinus prior to cardiac resynchronization therapy. So this is procedure that is done before the CRT to ensure that your lead is going to be safely placed in the right position in the coronary sinus. Then also to cross mitral valve in mitral valvuloplasty, balloon mitral valvuloplasty. This is the hub and these are the ports, and this is the body of the catheter. So this is just like a magnified image showing the balloon, and the balloon size also varies with the French size of the catheter. So medications, pre-medication, injection petidine, of course to relieve pain. Then Phenergan can be used also to prevent vomiting, nausea. Then saline infusion, heparin to flush all the tubings, catheters, and sheaths. Lidocaine for tissue numbing, anesthetic medication for relaxing the patient, and water-soluble contrast. I said earlier that it can be ideally it should be done under fluoroscopy guidance. So you have a contrast. Then it's only if that is not available that you do anatomy guided catheterization. So still talking about equipment, procedure tray should contain sterile gowns, gloves, towels, drapes, gauze, scalpel, needle, scissors, because remember that you're going to dissect. Then syringes for heparin, saline flushing, lidocaine. Then also there must be labels and marking to label medications. to know what is lignocaine, what is petidine, yes, skin prep solution, connecting or tubing. So we have an anesthesia machine, oxygen supply, non-invasive blood pressure monitoring, temporary pacemaker, like I said. In a situation you have a patient that already has a level 1 branch block, you don't want to take the risk that you could initiate an RBB and patient now has a complete heart block in the process. So defibrillator must be available, suction apparatus, equipment to perform the cardiac output studies, then activator clotting time equipment. Okay, so then power injector to inject your dye, fluoroscopy machine, guide wires, catheters. So the vascular accesses will be femoral vein, basilic vein, subclavian vein, internal jugular vein. So this is an image to at least show two of the accesses that are popularly used. So this is the internal jugular vein between the two heads of the sternocleidomastoid, and this is the subclavian vein just below the clavicle. So multiple sites can be used for introducer placement. However, a site that can be readily compressed, should in case there is bleeding, such as internal jugular vein, is preferred. Localization and entry into the vein is best performed under ultrasound guidance as an image guided approach. Decreases procedural complications. So there's no issue, such complications like you are puncturing the carotid artery instead of the internal jugular vein. Cannulation of the vein utilizing anatomical landmark should only be done when ultrasound guidance is unavailable. So now the technique. So a local anesthetic is administered subcutaneously at the access site, and 18 gauge needle or 21 gauge needle, depending on the access site you want to use, would be used. So once venous access is obtained, a appropriately sized sheet, like I said, can be between 5 to 7, is placed in the vein and secured. Then the pulmonary artery catheter is advanced. Sometimes you use guide wires, but if it's possible for you to be able to advance your pulmonary artery catheter through the sheet so if you don't have any resistance, so you can go ahead. So if the catheter advances easily, no need for use of wire. Catheter will reach the right atrium from the internal jugular vein within roughly 20 centimeters. So if you're coming from femoral venous access sites, like I said, there are other sites. Although the femoral venous access site is said to be plagued with a lot of infections, so it's less used. Then basilic vein can also be used. So if you are coming from the femoral venous access site, to take about 45 centimeters to get to the right atrium. So nonetheless, the catheter movement can also be observed using fluoroscopy. So of course, if you can imagine it, it will be more difficult to come through the femoral vein than to come through the internal jugular vein. So when the catheter reaches the right atrium, a pulsatile right atrial waveform will be observed, and usually it's basically the wave of the jugular venous pressure. And prior to recording the pressures, a reference is established by zeroing. There's something called zeroing, and said it involves opening the air fluid transducer to the air so that it equilibrates with atmospheric pressure. When this is being performed, the air fluid transducer must be at the level of the heart, as if it is above or below the level of the heart, it can lead to false pressure measurements. So once right atrial pressure waveform is obtained, the catheter is manipulated to turn towards the right ventricle, and the RV pressures are also obtained. Following this, the catheter is usually advanced to a wedge position. So from the right ventricle, it advances into the pulmonary artery and then into the wedge position. That's the pulmonary capillary wedge pressure, whereby the pressure recorded there is usually a reflection of the pressure in the left atrium. So once this is done, the balloon can be deflated and brought back a few centimeters into the pulmonary artery, where pulmonary artery pressure can also be recorded. It is important to know that all pressures should be measured at end expiration, and the pulmonary artery blood sample is drawn using the distal yellow pot, and mixed venous oxygen saturation can be obtained. So as you move from one chamber to the other, blood samples can be taken for you to know the oxygen saturation. I know we have answered questions on what's the saturation in right ventricle, right atrium. If you have a left to right shunt, what level of saturation will you get? So this is where all this plays out. So arterial saturation has to be obtained separately as to determine. So if you want to now, so the additional benefit of being able to assess the cardiac output comes there. So you can take samples and check the arterial saturation. I think the way it is done is that you check the difference between that in the pulmonary, that in the pulmonary vein, and you can use it to compute your cardiac output using the FIT method. Then the thermodilation method is that you're going to inject cold saline through the blue port into the right atrium, where it mixes with blood and the temperature difference. So as that saline moves from right atrium to right ventricle, you measure the temperature of the blood, and then the values gotten can be used uh to compute the cardiac output, and it must be done at least 3 times to get an average of the cardiac output and cardiac index. So the pulmonary artery catheter can be manipulated and placed in the superior or inferior vena cava too, for checking blood samples and estimating oxygen saturation. If you remember, we said that the oxygen saturation in the superior vena cava is much more lower than what is in the inferior vena cava. So all of this, so checking to be sure that they are normal. So this is flotation of the pulmonary artery catheter. So you can see it's coming from the right atrium, from the internal jugular vein access site, and this is the balloon. So it's advancing. So as it's advancing, so this is you can see this is the JVP pressure wave, and then as it moves into the right ventricle, so you can see there's an increase. So the systolic wave in the right ventricle, and then as it moves into the pulmonary artery, there's a step up. You can see that stepped up here. So the systolic pressure has stepped up here in the pulmonary artery, and then back, and then extend into the pulmonary artery to the wedge side, and so it has stepped down. So this is still the same thing from the previous, but only that this shows like an idea of the pressures that are measured there. So right atrial pressure 0 to 6 millimeters of mercury. Pulmonary artery pressure, the mean is between 10 to 20 millimeters of mercury, and the capillary wedge is between 8 to 12 millimeters of mercury. So this is with there's an attachment of the ECG to the pressure waves that are recorded in the pulmonary wedge. Okay, so still the same thing, showing the average pressures. Okay, so hemodynamic parameters that are measured. So have the central venous pressure is recorded from the proximal port. And usually the central venous pressure is equal to the right atrial pressure. Then also equal to right ventricular end diastolic pressure when there is no obstruction between the chambers. So that's the condition, that there is no tricuspid stenosis or anything obstructing the flow between RA and RV. So the pressure between the two would be equal and be equal to the central venous pressure. Then the pulmonary artery pressure, measure that the tip of the pulmonary artery catheter with balloon deflated, and it reflects the RV function, pulmonary vascular resistance, and early filling pressures. Then the PCWP is recorded at when the balloon is inflated and is equal to left atrial pressure, like I said, as long as there's no obstruction between the left atrium and left ventricle. The PCWP is equal to the left atrial pressure and also equals to the left end diastolic pressure. The cardiac output is calculated from the thermodilation technique, like I said earlier. Then the cardiac output can now be estimated using even saturation. So the difference between the pulmonary vein oxygen and the pulmonary artery oxygen saturation. So this is a table showing the average values that are measured in the different chambers. The pulmonary artery, 8 to 20 millimeters of mercury, wedge pressure 6 to 12, RA 0 to 8. So this, like I said, that it's not restricted to just cardiac conditions alone. We have seen cases of other causes of shock. So from what I have said so far, can be able to say, okay, for in case of shock, the blood pressure is low, blood pressure is low in all of them, but all these these particular values will be able to let us know which type of shock exactly it is, and it will be able to guide fluid management and therapy. So the pulmonary capillary wedge pressure would be low in distributive shock, would be low in hypovolemic shock. So you know you need to give fluids, but will be high in cardiogenic shock. Then cardiac output will be low in cardiogenic, low in hypovolemic, but can be high in distributive. Then the resistance, so it can be high, normal, or low in cardiogenic, but will be high in hypovolemic, will be low in distributive. So this is showing constitutive pericarditis and restrictive cardiomyopathy. let me still advance. So you can differentiate the diastolic dysfunction between different conditions: constitutive pericarditis, RV infarct, tamponade, restrictive cardiomyopathy. So I'll still talk about it with images. So I think it will help us to understand more. Okay. So in acute MR, so I'll now start going through examples of conditions and what their waveform will look like on right heart cath. So in acute MR, for example, acute myocardial infarction with rupture of the papillary muscle, you have an acute MR. So there's regurgitation, and it produces a large V wave in the atrial pressure that occurs after the ECGT wave. So the V wave may be modest in a chronic MR because there is already chronic atrial dilatation, but in the acute MR, that atrium is not prepared. So the V wave will be more prominent. So other cases of prominent V wave are TR and VSD. So this is acute MR. So looking at the I'm sorry. So looking at the pulmonary capillary wedge pressure, you can see it's elevated here. It's elevated, so it will be high. And like for example, just like I said that, so the pulmonary capillary pressure indicates the pressure that is in the left atrium and even in the left ventricle, as long as there is no obstruction between them. So with that massive backflow of blood in acute MR, for example, in AMI, with rupture of capillary muscle, so you have the pulmonary capillary wedge pressure stepping up. Okay, so this is right ventricular infarction without tricuspid regurgitation shown on the right, and with tricuspid regurgitation, okay, on the left without right. So looking at this is you can see the V wave. Like I said, you will have a large V wave. And if you remember in our JVP wave, this V wave signifies the filling of the right of the atrium against a closed valve, against a closed tricuspid valve. So it's this ditto for the left side, filling of the LV against a closed mitral valve. But now that there is and there is a tricuspid regurgitation, so this is talking about the right side. So there will be a large V wave, and this is the Y descent. So, but you cannot see that here because there's no tricuspid regurgitation here. So you can't, the V wave is not large here, but it's large here. So cardiac tamponade, the hallmark in that cardiac tamponade is there is a diastolic equalization of the pressures, where you have the RAP is equal to RVP to pulmonary capillary wedge pressure, and are all increased. So it's usually characterized by a deep X descent and an absent Y descent. So this absent Y descent is usually due to the fact that there's an early filling of the ventricles, which is halted. So in the late part of the ventricular filling, the constriction or the limitation provided by the tamponade does not allow you to have that Y descent. So I'll show the image now. So it's due to lack of RV filling at the beginning of diastole. So this is cardiac tamponade. You can see. So this is the X descent. This is the V wave. You can see that instead of this to go down, there's a blunting. So there's no Y descent because the cardiac tamponade is not giving room for the LV to fill. So this is depicting the right atrial pressure, the pulmonary artery pressure, and the pulmonary capillary pressure. So you see that the pressures they are equal, corresponding. So constitutive pericarditis is characterized by brisk ventricular filling during early diastole and limited ventricular filling during late diastole, and they have this deep and plateau waveform. So it can be seen in constitutive pericarditis, restrictive cardiomyopathy, RV infarct, and massive PE. So this is the deep. This is the deep I'm sorry. So this is the deep, and this is the plate 2. So, complications. Establishment of, so the complications can be divided into 3 groups. So there are complications of trying to establish the access. There are complications of that come from the positioning of the catheter itself. Then so I'll just start with the ones that has to do with the central venous access. Can be accidental puncture of adjacent arteries that would lead to bleeding. So, for example, using an internal vein access and then you puncture the carotid artery, then that's why it's good to do it under fluoroscopic guidance or ultrasound guidance. Then can have neuropathy, air embolism, pneumothorax. If you are coming through the subclavian vein, there can be a risk of pneumothorax puncturing the lungs. Then also the pulmonary artery catheterization itself, in advancing the catheter, the Swan's catheter, it could cause dysrhythmias, such as premature ventricular or atrial contractions, VT or VFib, right bundle branch block can happen. Then in patient with LBB, it can lead to complete heart block. So minor increase in tricuspid regurgitation is also a complication. So from pulmonary catheter residence itself in the right heart chambers, it can have thromboembolism. It can have mechanical complications such as knotting of the catheter within the chambers. Then pulmonary infection, endocarditis, endocardial damage can occur. Then there can be damage to the cardiac valve. Then pulmonary artery rupture, which is said to occur in 0.03 to 0.2% incidence with 41 to 70% mortality. So this is a table grouping the complications. Like, it's just a summary of all that I just said recently. Thank you.
All right. Thank you. Thank you. Thank you. Thank you so much, Dr. Kedara. Thank you for.
I'm sorry, there's something I want to share. Maybe it would also like a video, just to end it. And
Okay. Okay. Go ahead, please.
I hope it will share.
The pulmonary artery or Swan-Ganz catheter is a balloon flotation catheter that directly measures multiple physiologic values. In this demonstration, we will review the anatomy of the catheter and the pressure waveforms obtained as the catheter is
We are hearing, but we are not seeing.
Okay.
The pulmonary artery
Then there
catheter
is
a
an
multi-lumen
issue.
catheter
Sorry.
with
So
markings at each 10
I don't know
centimeter
exactly why.
interval.
I have shared. So let me
Each thin
stop.
dash represents 10 centimeters.
I don't know why it's not. I wish it would show. I don't know why.
How did you share it? Are you sharing your screen or you are sharing the video?
I'm sharing. Okay, let me try again.
Okay, now it's coming now. Okay, it's your slides that is showing.
So these are my slides that are showing. Okay, let me see. Okay, maybe I should share. Let me see. Okay, so okay, let me stop sharing and then try again. Okay, maybe this. Can you see anything?
It's showing now. Yes, go ahead and
Showing
play.
now. Okay.
The pulmonary artery or Swan-Ganz catheter is a balloon flotation catheter that directly measures multiple physiologic values. In this demonstration, we will review the anatomy of the catheter and the pressure waveforms obtained as the catheter is floated into the pulmonary artery. The pulmonary artery catheter is a multi-lumen catheter with markings at each 10 centimeter interval from the tip. Each thin dash represents 10 centimeters and each thick dash represents 50 centimeters. For a standard VIP catheter, the lumens include the thermistor port, which measures blood temperature for cardiac output calculations, the blue CBP or proximal injectate port, which terminates 30 centimeters from the catheter tip, the yellow or PA distal tip port, which terminates at the tip of the catheter, the balloon port, which is used to inflate the balloon at the tip of the catheter, and the white right atrial or proximal volume infusion port, which terminates 31 centimeters from the catheter tip. The PA catheter is initially advanced through the introducer sheath into the internal jugular vein, subsequently traverses into the superior vena cava and then the right atrium. At this point, the monitor will demonstrate a central venous pressure, or CVP waveform, which consists of 5 phases, 3 peaks, and 2 troughs. In order of appearance, the A wave corresponds to atrial contraction. The C wave corresponds to movement of the tricuspid valve into the right atrium during isovolumic ventricular contraction. The X descent corresponds to atrial relaxation. The V wave corresponds to systolic filling of the atrium. And the Y descent corresponds to early ventricular filling. Here, the balloon is inflated and the catheter is advanced with each heartbeat. As the catheter traverses the tricuspid valve, right ventricular pressures will be measured and will appear on the monitor as a marked increase in systolic pressure. A right ventricular waveform is seen with a steep systolic slope. As the catheters advance further, the PA catheter will then float across the pulmonary valve into the pulmonary artery, displaying a PAP waveform. In comparison to the right ventricular pressure waveform, there's an increase in diastolic pressure, also known as the diastolic step-up, when the catheter is in the pulmonary artery. The most distinct feature seen on the PA tracing is a downslope in the pressure tracing during diastole. We will now demonstrate insertion of a PA catheter in a patient. The PA catheter is first advanced through the introducer sheath to the 20 centimeter marking with the balloon deflated. It is important to recognize, however, that the catheter emerges at 13 centimeters. The tracing on the monitor should be observed carefully at all times. As the catheter rests in the right atrium, the monitor demonstrates a CVP waveform. The 3 peaks and 2 troughs are visualized. The balloon is now inflated and the catheter is advanced with each heartbeat. The transition to a waveform with a steep systolic slope suggests that the catheter has traversed the tricuspid valve into the right ventricle. Insertion of the catheter is periodically paused to emphasize the waveforms for teaching purposes. As the catheter is advanced further, an increase in diastolic pressure, also known as a diastolic step-up, is seen. This suggests that the tip of the catheter is now in the pulmonary artery. A study published in 2006 measured the length of insertion to the right ventricle,
Okay, I think
pulmonary
that's,
artery, and wedge position of pulmonary catheters in
I think
300 adult
that's all.
patients in India through the right
Let me
internal
just
jugular
stop.
vein.
Okay, so I think that brings me to the end of my presentation.
Wow, wow, wow. Thank you so much, Dr. Kedara. Thank you, thank you, thank you.
Thank you for the opportunity.
All right, it's time for questions from the class. Then after which we take comments from, I can see Prof on the call and Dr. Joe and our other consultants. But let's take questions from the class. So I don't know, you can just unmute or raise your electronic hand and I will be able to recognize you. I expect that there will be a lot of questions. It was actually a very interesting and exciting presentation. I don't know, do we have any questions? Dr. Onyinye, Dr. Mokorede, the Port Harcourt man, Dr. Ovunda. I don't know, do we have Dr. Amina questions? Dr. Felix?
No question, Dr. Corey.
Okay.
Thank you.
Okay. Anyone at all? Okay. Was actually Dr. Kedara, that means your presentation was actually very, very superb. They say that when there are no questions, it means two things. Either it was well understood or it was not understood. So in this case, I believe it was very well understood. So right now we'll take comments from our chiefs. Dr. Joe, I don't know whether you have is there any comments from you before I call Prof? Okay, then let me move. Prof, sir, good evening, sir. I don't know whether we have, I don't know if there are comments from you.
Good evening.
Good evening, sir.
Presentation by Dr. Okeda. Nice presentation, madam. Yeah, so one first thing I want to also draw attention to that she had discussed is assessment of cardiac output in right heart catheterization, or the various methods of assessing cardiac output, because that's one of the primary reasons for doing cardiac catheterization. So she tried to discuss the fix, the thermodilation method. We should all know the different methods of assessing cardiac output, both invasive and non-invasive. In the slide, it looks a little bit mixed up, but I think maybe she will help us modify that segment on the different methods of assessing cardiac output, the invasive and non-invasive method. Number two important thing we also want to state here is when you are doing right heart characterization, you are trying to make a diagnosis, right? So your main aim is not just to, as she discussed at the area of indications for cardiac characterization. So you are not just going there because you want to confirm pulmonary hypertension. That is not all. She are trying to describe different conditions that can be assessed with cardiac characterization, from valvular disease to cardiomyopathies to tamponade. But we need to know the details also of those individual conditions, which might not be covered in this kind of lecture. So for example, if somebody has restrictive cardiomyopathy, how do you differentiate that from constrictive cardiomyopathy? How do you differentiate that from tamponade? All those pressure waves and things like that. It's part of cardiac characterization, but might not be actually umbrella under this presentation. So we should know that for exam purpose. Also, there was a formula she dropped for cardiac output there, which I know is the fixed formula for assessing cardiac output. That formula might not be what you think. So there's a formula there where she said cardiac output is equal to oxygen consumption all over. Yes, you can see that formula, the last line. So, because the question they would ask you will be, or in reality, you said saturation of the pulmonary vein minus artery from minus pulmonary artery. So question is, how do you get the saturation of the pulmonary vein? You have described how the catheter will get to the pulmonary artery. Yeah, so they can take sample from pulmonary artery, from through the catheter, and assess the ABG, the saturation. But the question now is the pulmonary vein that you put there, how do they get there? You get what I mean? So that is why there's a modification to this formula. Okay. So number two important. So that place where you put pulmonary vein actually is the arterial aortic saturation, aorta. So it means that whatever you're getting in pulmonary vein, the same thing that will get to the left atrium, that will get to the left ventricle, that will get to the aorta. So aorta sample is easy to collect compared to going for pulmonary vein. If the patient does not have an ASD, how do you get to the left atrium and collect pulmonary vein sample?
Okay,
So is why you need to understand that formula well. Then also important to know that this is just formula for cardiac output when the patient does not have a shunt. So that means the patient does not have either ASD, VSD, or PDA. There's no shunt. That is when this formula is useful. But when there is a shunt, then this formula cannot hold waters, okay? So you should know the formula also for cardiac output when there's a shunt. So this is important. So, but by and large, this is just a fantastic presentation. I
Thank you,
don't
sir.
think I have much to say. Thank you very much.
Thank you, sir.
Thank you so very much, Prof. Thank you, sir. I don't know if there are no further comments. I think we'll go over to our MCQs. Chief Eugene, I don't know if so I can save this presentation as a file.
Thank you very much, Charles. A million apologies to all the consultants and fellows, and especially to Prof, for asking him to help out, and I wasn't around. I had an emergency. I was called to the hospital. But from the comments I heard, I can tell the presentation was very good. Thank you very much, and we are grateful. So we'll continue with the MCQs.
Eugene, sorry, how do you normally do it? Do I leave or I don't know, how do you normally?
No, so you can give the host you can make me co-host and assign the host, then you log off. Immediately you go off, automatically to start converting.
Okay. So just sign the host. You're a co-host now.
Yeah, so just make a co-host. Then you just log off.
Okay.
Like when you go off, automatically to start converting, then you can now join the Zoom again.
Okay. So
And when it's done converting, there'll be a pop-up menu. Then you decide which folder you want to store it in.
Okay.
And that's
okay.